Welcome to Made One Pager. My name is Benjamin, and today I'm going to talk about endocrine pancreatic tumors, and these are very important tumors when it comes to examinations. And they have a lot of things to put together, a lot of concepts, a lot of syndromes, a lot of specific clinical features. So we're going to look at them, try to differentiate each from the other. At the end of the video, we shall look at general investigation and how escalation of therapy is done to really bring everything together in a quick and summarized way. So when we look at endocrine tumors, these are going to represent actually 1 to 2% of all pancreatic tumors. So they are not the most common, but no, when it comes to exams, they have most of the high risk things. So the incidence is rising due to the widespread use of CT and MRI, which have led to the incidental detection where probably we do a scan for something else and then end up discovering there is this tumor going on. So when we look at the genetic dispositions, if I was to remember two genetic conditions that are very important when it comes to pancreatic endocrine tumors, I would consider the main one syndrome and the Van Hippel-Lindau disease. These two are the most commonly implicated, and then we have the tuberous sclerosis and the neurofibromatosis. And when it comes to Van Hippel-Lindau, these people most of the times have uh, multiple pancreatic neuroendocrine tumors. And when it comes to main one, most of the time it's insulinoma and gastrinomas, and they're going to be multifocal. So when you look at the classification of these pancreatic tumors, we can classify them into two. We have the functional tumors and the non-functional tumors. And when it comes to the functional tumors, we have the insulinomas, which produce insulin. We have the gastrinomas, which produce gastrin. We have glucagonoma, which produces glucagon. We have VIPoma, which produces active intestinal peptide, VIP. And we have somatostatinoma, which produce growth hormone, is somatostatin. Then we have the rare ones that could be producing other hormones like ACTH, GRH. And this is not surprising because when you look at these tumors, they're coming from neuroendocrine cells, and neuroendocrine cells are basically all over the body. We have them in the lungs, we have them in very many places. So they have a potential to produce all other kinds of tumors depending on how how the differentiation goes on. So the WHO has a grading which considers the Chi67 and the mitotic rate, and we have the G1 which is G1 neuroendocrine tumor, G2 neuroendocrine tumor, and then the G3 neuroendocrine tumor. Depending on the Chi67, if it's less than 3, it's a G1. 3 to 20, it's a G2, and greater than 20 is a G3. And then we have the neuroendocrine carcinoma, which is poor differentiated carcinoma, and this is very highly aggressive. So starting off with the past pancreatic tumor, that is the insulinoma. So the insulinoma is basically a tumor that is producing insulin, and it is the most common pancreatic neuroendocrine tumor, and it's also the one that has the highest chances of being benign. The rest, most of them have malignant potential, a high malignant potential. So 90% of these insulinomas are going to be benign and solitary, whereas 10% are going to be malignant. So the most common presentation is going to be the Whipple's triad, and this is most of the time a bit diagnostic, and we support it with a few labs. So what happens is that we have a fasting hypoglycemia where someone has low glucose on fasting. They have a glucose less than 50 milligrams per deciliter recorded. So we have a recording of hypoglycemia as well as symptom relief glucose. And most of the time, these patients don't have symptoms of hypoglycemia like palpitations, tremors, sweating, confusion, seizure, and behavioral changes. And these are going to come from the low glucose that activates the adrenergic system. So this patient will present with these symptoms. And then when we do the laboratory investigations, most of the time we'll find that the insulin is high as well as the C-peptide. And the C-peptide being high helps us rule out factitious insulin use or the non-rational insulin use, or maybe someone has injected themselves with insulin. So if it's exogenous insulin, most of the time we don't have a C-peptide rising. And when it's coming from the pancreas, we're going to have the C-peptide also high. Then we can do the fasting test that can confirm, but this one requires close monitoring. So the patient is allowed to fast, and then we want to measure the insulin or the glucose serially and see how it decreases. Then after we have confirmed or we have suspected that we have this insulinoma, we want to localize it where we do a CT or an endoscopic ultrasound. And the endoscopic ultrasound is good in cases of pancreatic tumors because you are able to place the probe within the stomach duodenum next to the pancreas, and therefore it's easier to get these tumors. And then the distribution of most insulinomas is equal in the head, the body, and the tail. So we can find them equally in any of those locations. And the treatment is enucleation most of the time if the tumor is away from the main duct. But otherwise, you want to do a distal pancreatectomy or you want to do the Whipple's surgery. Then main association, 10% is going to be associated with the main one. And when we have main one, most times it's going to be multifocal. So we might have more than one insulinoma in this condition. Then an important condition to identify is the non-insulinoma hyperinsulinemic hypoglycemia, which is called nesidioblastosis. And this one occurs when you have beta cell hyperplasia. So it occurs in conditions recently or historically, it used to occur in neonates who are born to diabetic mothers due to that hyperglycemia they experience, whereas in utero, beta cells would hypertrophy, produce enough insulin to go down, and on birth, the beta cells being large as to producing a high amount of insulin, these children get into hypoglycemia. But now it is being seen even in older individuals, and that is 2 to 5 years after they have done the Roux-en-Y gastric bypass. And it is also caused by prolonged incretin. And these ones are GIB or GLP-1. And the management of this most of the time is just to convert the bypass back to the normal flow, the stomach, and then you want to add a restrictive element. And pancreectomy alone is ineffective because of the enteroinsular, because the enteroinsular axis persists. Then we have glucagonomas, and glucagonomas are majorly going to present with 2 hallmarks, and that is diabetes and the necrolytic migratory erythema. This is a very important rush when it comes to diagnosis of glaucoma, and most of the time it's going to be confused for other things like eczema. So you have this rash that is neburizing and it is migratory, and it may be in areas like the perineum, perioral region, the abdomen, and the feet. Then others, we have glossitis, we have weight loss, malnutrition. And remember, glucagon is catabolic or is anti-insulin, so it prevents the pill. So we don't have weight loss as well as features of malnutrition in these patients. Then serum glucagon will be greater than 500 picograms per ml if you measure that. And preoperatively, we want to control the diabetes. And that means we want to give things like insulin, we want to give nutritional support, and then we want to give octreotide, which is a somatostatin analog. And we're going to see how octreotide or somatostatin analogs are very important in the management of these neuroendocrine tumors. Then the location are mostly in the body and the tail of the pancreas, so they're not common in the head. And then treatment, sometimes you can do the debulking if it's operable. Then when you look at the gastrinoma, and this one is associated a lot of the times with what we call the Zollinger-Ellison syndrome. So what happens is that we have this tumor that produces gastrin. And remember, gastrin is the hormone that influences the production of the acid in the stomach. So what happens is that these people most of the time have severe acid hypersecretion and refractory or multiple ulcers. The patient comes in, they have a history, they have been taking proton pump inhibitors for a long time, but all the time they stop them, most of the time the ulcers come back. And then they also have diarrhea in 21% because of this acid hypersecretion. The acid kind of causes this diarrhea. So when you're doing the diagnosis, it's important to rule out other causes of increased gastrin. If a patient is on proton pump inhibitors, you want to stop this because proton pump inhibitors prevent the production of acid. And the acid is supposed to give a feedback to stop the production of gastrin. So when when you're taking PPIs, the acid will be high. And other things. Then the serum gastrin greater than 1000 picograms is normally the diagnostic one. And if borderline, you want to use a secretin stimulation test. So when you give someone, when someone has this gastrinoma and you give them a secretin, most of the time they are going to have an increase in the gastrin. So differentials for gastrin, we have pernicious anemia, where we have autoimmune destroying the cells that produce this hydrochloric acid, proton pump use, renal failure, because the kidneys are responsible for for clearing this gastrin from blood. So if we're having renal failure, gastrin is going to be high. Gisel hyperplasia, atrophic gastritis, gastric outlet obstruction. So you want to rule out also things like H. pylori. And vocation of these gastrinomas is very commonly found in the Passarus triangle. That is the area between where we have the CBT, the CBD, and the cystic duct joining, the duodenum, and then the pancreatic neck and body. So this is the location of most gastrinomas. It's important as the Passarus triangle, and sometimes it's called the gastrinoma triangle. Then we want to rule out main one, serum calcium, because in main one we also have tumors of the parathyroid. And when we have high calcium, calcium can contribute to the uh, to the to the production of acid in the stomach. So it's important that you rule out this main one, or you do a serum calcium and rule out the parathyroid tumor. Then surgery, you want to do aggressive resection for psoriatic tumors. For main one, you want to treat parathyroid disease first. And then you want to remove lymph nodes in the Passarus triangle. You can do enucleation if it's not involving the duct, and then pancreatic resection for solitary tumors without metastasis. Sometimes you have liver metastasis. If they are limited, you can do resection. If not, you can do debulking. But that is going to be unhelpful when you have main one. Then medical treatment, you want to give BPIs because we have a lot of acid. Stop that. You want to give somatostatin analogs, and as I told you, octreotide is very important. Also, somatostatin analogs are important when it comes to these neuroendocrine tumors, because these neuroendocrine tumors tend to have a lot of these somatostatin receptors. So when you get something that covers that or that competes for that, you're going to have those tumors shrinking or delaying the progression of these tumors. Then outcome, a third, achieve a biochemical cure, and we have excellent long-term survival if there are no metastases. Then we're going to look at the somatostatinoma. So the somatostatinoma is a tumor that produces somatostatin, and somatostatin is a growth hormone, and we know that growth hormone is naturally the enemy of insulin. So these people have inhibition of insulin, bile, and pancreatic enzymes, and they develop gallstones, diabetes, and steatorrhea. And location is most commonly going to be found in the periampullary region and proximal pancreas, and the presentation is going to be of abdominal pain, jaundice, and cholelithiasis. So you see this patient coming in with abdominal pain, they have jaundice, and then they have cholelithiasis, and the diagnosis is going to be, we're going to measure the serum somatostatin, and it's going to be greater than 10 nanograms per ml, and this is going to be mostly metastatic, and we want to sometimes attempt complete resection plus a cholecystectomy if as prophylaxis for the gallstones. Then we have the VIPoma. This is also another important when it comes to examinations, or called the Vanna-Morrison syndrome. So what happens? Also, sometimes we call it the WDHA syndrome, and this is going to be because it's characterized by patients having watery diarrhea, that's the WD, hypokalemia, and achlorrhea. So what happens is these patients produce a lot of intestinal peptide, and this is going to increase the motility within the motility as well as the secretions within the intestines. So they're going to have diarrhea up to 5 liters per day, and it's episodic. And this diarrhea is going to be even most of the time the diarrhea is going to be refractory to loperamide, which is an anti-diarrhea drug that we commonly use. And want to measure VIP levels repeatedly. You have episodic secretion. Then localization, the cytoendoscopic endoscopic ultrasound are very important. And the preoperative, you want to aggressively correct the fluids erectile. So you're seeing this patient is doing oral up to 5 detergent diarrhea every day. So really have to emphasize in the electrolytes. And location is mostly in the distal pancreas, and it's the most metastatic at diagnosis most of the time. By the time someone is diagnosed, unfortunately, we have little metastasis in the treatment. We have debulking. We can use somatostatin analogs, and hepatic artery embolization may help, especially because we have these metastases to the liver. And at the end of this video, during the management, we are going to cover and see how we escalate the management most of the time in these pancreatic neuroendocrine tumors. So when we look at the investigations that we can do, we want to do laboratory investigations. We can do hormone-specific assays, and chromogranin A is one of the most important hormones. So most of the time when we have a pancreatic tumor and you want to rule out, is it neuroendocrine, is it not? The first test that you want to do is going to be, the first test that you're going to do is going to be the chromogranin A. And this is going to tell you, is my tumor malignant? Is my tumor neuroendocrine in nature or not? And then we have to know that sometimes PPI are going to falsely elevate the chromogranin A. Then the imaging, the most important imaging is, or one of the most important is the CT. And for this one, we are going to do the triple phase pancreatic protocol, whereby we are going to inject this contrast, take the images during the arterial phase, that is early, the venous phase, and also when the blood flows in other organs. So there are 3 phases, and it's important to understand that protocol when it comes to the CT. Then the MRI is excellent for identifying liver metastases. Then the endoscopic ultrasound and fine needle biopsy can be done for small lesions, necessarily when you need to do the I67 sampling, which will grade for us that tumor. Then you have the GA68 data PET CT, and this one is just a CT whereby we have visit for staging and for planning for the peptide radionuclide receptor therapy. So what we do is that we are doing a scan whereby we have a radioactive somatostatin analog that we inject, and then when we do the scanning, the tumors, the neuroendocrine tumors, have a lot of receptors for this somatostatin or for this. So they are going to take it up, and when they take it up, you shall be able to localize where these tumors are. And also, if you're taking it up, then you know that they have the receptors. Then we can target those receptors. Then we have the 4-deoxyglucose FDGP PET scan, which is for the high grade. That is the T3 or the neuroendocrine carcinoma, because we know tumors take up a lot of glucose. So we use this for deoxyglucose. That is, of course, radio labeled, or that we can see with our PET scan. So when the tumor takes it up, we shall know where the tumor is. And then histology, we want to confirm neuroendocrine tumors with the markers, and also want to determine the I67 index that we use to grade the tumors. And then the management. We've looked at most of the management and the subsequent conditions, but surgery is one of the most important managements here. And in certain numbers, we can do an enucleation if they are less than 2 centimeters, or they're dark sparing. Whenever you have a gastrinoma, we have to put in the duodenum, because it is a common place where we have more tumors occurring with gastrinoma. So you want to look into the duodenum. If it's a body or tail, you want to do a distal pancreatectomy. If it's the head of the pancreas, we do the Whipple's procedure. If it's main one, it's often tailored, because main one is going to be associated with multiple tumors. So it is tailored and often non-radical to multifocality. Then when it comes to medical management, we want to control of hormone excess. And most of the time, we are going to use octreotide. And octreotide, remember, attaches to somatostatin receptors, and then you shall help decrease production of those hormones. If we have insulinomas, we use diazoxide, which reduces insulin production, and then we give glucose. In gastrinomas, we want to use high-dose proton pump inhibitors. Then we can do anti-tumor therapy, where we can use somatostatin analogs again. Remember, they're going to stop the proliferation of the tumor. And most of the time, if you have a big tumor or something that is unresectable, and maybe we have starting to have METs, we can do the targeted therapy, that is everolimus and sunitinib. And then we have the peptide receptor recombinant therapy, whereby we attach radionucleotide, that is Lu177, to our somatostatin analog. So when we go and attach the somatostatin receptors, the radionucleotide particles are going to affect only that place with those receptors. So it's going to reduce on the collateral damage with other cells. When you have chemotherapy, that is streptozasine or Captem for aggressive high-grade tumors. Then liver-directed therapy, when you have liver metastases, we can do the hepatic artery embolization, because most tumors are going to derive their blood supply from the hepatic artery, but the liver gets most of its blood supply from the hepatic portal vein. Then you have the RFA and radiofrequency ablation, as well as the SBRT. And these ones are just forms of radiation whereby we are trying to be more specific. So, for example, the SBRT is more, it's accurate up to a millimeter. So we've introduced on colorectal damage or other tissues. So we have looked at the different endocrine tumors of the pancreas, and I hope we are able to put everything together. Don't forget to like and share this video, put a comment and share it with a friend. My name is Benjamin. Till we meet again.